Next, I welcome Dr. Deepa MG, Associate Professor in GMC Ernakulam.
So now that we have seen the anterior and posterior segment findings, let us see what are the things that we are supposed to evaluate and document when a patient is sent to us for a toxicity screening. I would like to thank KSOS Scientific Committee and Dr. Sindhu for giving me this opportunity. Well, the relevant scenarios, we saw a large list of drugs involved, but the most relevant scenarios in which this become important is tuberculosis and patient is on ATT. When the patient is having arthritis, connective tissue disorders, when the patient is on HCQS, chloroquine, then long-term steroids in connective tissue disorders, nephrotic syndrome patients on long-term steroids, then chemotherapy agent-associated toxicities, patients on long-term anti-epileptic drugs, and last I have mentioned about allergic reactions in Stevens-Johnson syndrome. This as such is not a long-term ocular toxicity, but this is somewhere even with a single dose, the drug can cause serious ophthalmology implications, and hence this should always be kept in mind. Now, as always, we start with a good history with due importance to the disease duration, treatment duration, the drugs involved, the dose and duration of each of the drug, the past history to any of these drugs which may not have been properly documented in the medical records, and the other associated diseases that the patient may be having. This can lead to a masquerade of clinical findings as well as a modification of the drug metabolism in the patient's system. In examination part, first and foremost is, as always, visual acuity, which should be documented in each and every visit, and preferably the best correction with glass. Color vision is a very sensitive indicator of early toxicity, especially in ATT patients, and this can manifest even before a visual acuity or field loss occurs. In this also, blue-yellow color loss is more important, and the ideal chart that you have supposed to use is a Farnsworth-Munsell D15 chart. Recording a contrast sensitivity is also ideal with a Pelli-Robson chart. In anterior segment evaluation, we have already seen all the findings. In the cornea, you have to look for various deposits. In the anterior chamber, uveitis, depigmentation and other changes on the iris, ciliary effusion causing angle closure glaucoma, then deposits on the lens. In pupil, look for any changes like an RAPD or an afferent pupillary defect. Well, a fundus evaluation is not recommended as a screening tool of choice, because most of the changes occur later in drug toxicity. But as a part of our mandatory ophthalmology evaluation completion, we always do a fundus evaluation and take special, have us look at the optic disc, look whether it is normal, whether there is hyperemia, temporal pallor, and in macula for mainly parafoveal changes, especially in HCQS toxicity, like bullseye maculopathy and all the findings you already know. Many studies have shown that in Asians, the changes need not be parafoveal. It can be in the extramacular regions and also along the arcades. Recording of IOP is important, especially in patients on long-term steroids, inhalational, topical or dermatological use. In visual fields, in HCQS screening and all, the general protocol is given to be 10-2. But as I already told, the findings can be extramacular. Hence, a 24-2 or 30-2 is also recommended in Asians. In ATT, you can look for central or centrocecal scotomas. Rarely, a bitemporal scotoma or a peripheral field constriction can be noted. While coming to imaging in OCT, a spectral domain OCT is always better because of the better resolution. Look for localized thinning and loss of photoreceptor layers in the parafoveal regions. In optic nerve head, retinal nerve fiber layer thickness, ganglion cell thickness and volume loss is important. Macula, look for the changes of drug toxicity as well as look for any pre-existing macular disease. Fundus autofluorescence is another important investigation that you have to do, which show autofluorescence early, increased autofluorescence early and later dark areas of reduced autofluorescence as the RPE loss occurs later. This gives a topographic view of the damage. Coming to ERG, in central retinal function assessment, a multifocal ERG is better because a full field ERG may be most of the times normal. This gives an objective functional assessment even when there are not many structural changes. The various waveforms N1P1 N2P2 mainly represent the outer retinal function, and there can be reduced amplitude seen in areas 1 and 2, which represents the fovea and perifovea respectively. Then VEP is not as such mentioned as a screening protocol tool, but in ethambutol toxicity this is very important. There can be reduced P100 amplitude and latency, and in combination with multifocal ERG, this is said to be an important tool in keeping the patient on screening, whether to look for whether the patient is having reversal of the findings when you stop the drug or whether there is any worsening. So this as such, in combination with multifocal ERG, is an important tool for screening and keeping the patient on follow-up. Thank you for your patient listening.
Thank you, Dr. Deepa. That was an enlightening presentation and for clearly defining what all is not to be missed in a patient and for screening.